Our next presenter is Dr. Mirna Adel. Dr. Mirna is a teaching assistant of pathology at Faculty of Medicine, Ain Shams University. The presentation is entitled The Easily Forgotten Tumor.
Oh my God. Okay, good morning, dear colleagues. I'm Mirna Adel, teaching assistant of pathology at Faculty of Medicine at Shams University. And I'm going to take you all through my presentation, The Easily Forgotten Tumor, under the supervision of Professor Dr. Shaimal Gohari, my dear mentor, and then the Associate Professor and Consultant of Pathology at Faculty of Medicine at Shams University. Our case for today is a female patient, 61 years old, presented by left hilar in the bronchial mass. So by CT chest, it showed left upper lung lobe, ill-defined active cavitary mass with encysted collection measuring 6 times 9 times 9.5 centimeter, with near total collapse of the left lower lung lobe, showing an ill-defined patch heterogeneous uptake, and also a metabolically active prevascular and aortopulmonary left hilar lymph nodes measuring up to 3 times 5. So we started the workup of the case with a biopsy that showed only cores of lung tissue, which revealed chronic inflammatory reaction with the scattered lymphocytes and plasma cells, and leukocytic aggregates with moderate fibrosis with no malignancy. So it showed a partially organized pneumonic process. So another biopsy was recommended, and it came up with a specimen which revealed blood clots, mucus, and fibrin entangling inflammatory cells and strips of epithelial cells with moderate to marked nuclear polymorphism and loss of polarity, as we can see here. So it gave the diagnosis of superficial biopsy, which revealed high-grade dysplasia. So this also was inconclusive. So another biopsy came up. So here we can see the third biopsy that was taken from this patient from the left hilar in the bronchial mass. So as we can see here with the power 100, we can see bronchial wall with the respiratory lining. On going high power, we can see the underlying tissue, which showed a cellular tumor formed of epithelial cells having monotonous round nuclei, which are arranged in solid groups and trabecally, with intervening densely packed spindle cells with atypical nuclei. And the mitotic index here is, as we can see, is 3 over 10 Bernard power field. Also, we can see here areas of necrosis among the tumor. So what we have here is an epithelioid and spindle cell neoplasm for immunohistochemistry. So we started by PAN-CK, as we can see here at the power 200, and on going high power, so it gave negative results with only positive staining of the respiratory epithelium. So for the TLE 1 times power 400, we can see only faint or weak staining, which was considered only negative. Okay, also the tumor cells were negative for the PAX8. And on the power 200 for TTF1, also the tumor cells gave negative results. We have done chromogranin, which gave also negative results. Okay, so we have done creatinine, which gave positive results for the tumor cells, and also the tumor cells were 5% of them were positive for Ki67. We have done inhibin after that, which gave positive results for the tumor cells on the power 200, as we can see here. On going high power for the inhibin immunostaining, we can see the positivity of the tumor cells. So what we have here is the tumor cells which give negative results for PAN-CK, chromogranin, synaptophysin, TLE1, PAX8, MATTF1, and also 5% of tumor cells were positive for Ki67, and the tumor cells were positive for creatinine and inhibin. So immunohistochemistry performed for all the expected differential diagnoses were negative. So re-examination was done, and we looked over the H&E slides again. On the power 100, we can see here the tumor cells. On going high power, we can see in the tumor cells the nuclear groove, as we can see here. And also for looking for the mitosis, we can see brisk mitosis, as we said before, about 3/10 per high power field. So on the re-examination of H&E, it looked like granulosa cell tumor, as we have oval cells with almost bland nuclei, focally nuclear grooves detected, but there is no history provided. So what we have here is to call the physician or the patient. So we called the patient that she gave history of a previous resection of an ovary 20 years ago, which is a long time. So we started reconsidering the granulosa cell tumor recurrence. So we have done ER on the tumor slides, which gave positive results with the score 7/8, as we can see here on the low power and the high power. So these findings are in favor of metastatic granular cell tumor. So what is granulosa cell tumor? So it is a late recurring and an easily forgotten tumor. It is a malignant originating from the sex cord stromal cells of the ovary, and it's uncommon tumor which presents 2% to 5% of all ovarian cancers. It's classified into juvenile type and an adult type. And the majority of the cases, as such our case, are the adult type. It's considered 95% from the classifications, and it occurs at any age, but the two peaks in occurrence at reproductive age and postmenopausal age. The incidence in Western countries is twice of that, the women in Asia countries. So what can present our patients? Approximately 22.5% of the patients have no complaints, but mostly present with symptoms due to adnexal mass or endocrine manifestations, and 10% with ovarian torsion and tumor rupture or hemoperitoneum, most associated with hyperestrogenism causing metrorrhagia, postmenopausal bleeding, but it is rarely associated with hyperandrogenism presenting with virilization or hirsutism. So GCT is a cancer with long natural history, and recurrence often happens after 5 years of follow-up. As here in our patient, it occurred 20 years after the removal of the ovary. So most cases diagnosed at stage 1 disease need long-term follow-up. So how can we present in H&E slides? We have patterns as in diffuse pattern, as we can see here, solid growth of tumor cells with angulated or pale nuclei and nuclear grooves, as we can see here. Okay, or trabecular pattern. And also we have microfollicular patterns resembling cool axonal bodies of the Graafian follicle. We can see here small follicle-like structures filled with eosinophilic material. And also we can see it as in macrofollicular pattern, which is the least common. The stroma of the tumor is usually hypervascular with variable amounts of fibroblasts and ceca cells. As we can see, darkly stained aggregates of granulosa cells containing ceca cells with pale vacuolated cytoplasm. And the mitotic activity is usually not brisk, only 3/10 per high power field, as we can see in our case. It gives positive with FOXL2, SF1, inhibin A, carotenoin, and also gives positive results with reticulin, S100, vimentin, WT1, CD56, and SMA. So what is the take-home message? A granulosa cell tumor are characterized for late recurrence, which happened in 10 to 33% of patients. The prognostic factors related with recurrence are the stage at presentation, patient's age, tumor size, extent of surgery, cell atypia, and mitosis. So the long-term follow-up is required in all patients with granulosa cell tumors because at least 50% of recurrences are found more than 5 years after initial treatment. So we have not to ignore asking about the past history of excision for an ovary or for granulosa. So the long-term follow-up is required for all patients as recurrences are found in more than 5 years after initial treatment. And these tumors recur rarely 5 to 30 years after the first diagnosis, but we also have to consider it and not to ignore such the past history. Thank you, Dr. Muhammad, and thanks for the Shefal Orman Hostel for giving such an opportunity. And thanks to my dear mentor, Professor Dr. Shaima El Gohari, for giving me such an opportunity too.
Thank you so much, Dr. Mirna, for such an interesting history, interesting case. Our next presenter is